It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back to the Pain Exam Podcast, and I'm here today to remind you of some great conferences coming up, such as ASPN. ASIP is in a couple of weeks. We also have this summer, or I should say more in September, Pain Week, as well as the Latin American Pain Society. And we have some great ultrasound courses coming up as well. I'll be teaching ultrasound this week in Manhattan for IV placements, followed by on May 17th for ultrasound-guided regional anesthesia and pain, followed by our next course in July. But I am doing private shadowing at your clinic or ours, in which we coach you through all the relevant nerve blocks or joint injections or even spine procedures in some cases under the ultrasound. So if you are interested, go to nrappain.org. We also have a virtual pain fellowship, which has the virtual on-demand ultrasound and regenerative medicine training, as well as the Miss Keyword Lecture Series and Advanced Practice Provider Pain Management course online, all for CME credits. And we just introduced the opiate sparing course for the VA. If you work for a VA and you want your institution to sign up for this opiate sparing pain management course, just go to the nrappain.org website where you'll find it. So this podcast today is based on an email I received from one of the docs who recently took the pain boards, and she gave me a list of a lot of things that they focused on, and surprisingly, not many interventions. I mean, there were a few, but a lot of this other peripheral stuff, which I guess I shouldn't be surprised. Oftentimes, they do want us to think more like physicians as opposed to technicians, and it's not just about the interventions in pain management, of course. Of course it's not. So she mentioned an obscene amount of content on peripheral vascular disease. So I'm going to talk about that today. I'm going to go over peripheral vascular disease, what it is, as well as the diagnosis, which is commonly or recently asked on the pain management boards. So, what is peripheral arterial disease? Well, it's a condition that, like arteriosclerosis in other vascular beds, it develops over a long term. The WHO defined it as exercise-related pain or an ankle-brachial index of less than 0.9, and that's specifically peripheral arterial disease. That's what I'm talking about here, okay? Common signs and symptoms in the lower limbs develop 5 to 10 years after the coronary stream. And acute ischemia can also increase because of the following reasons. 1, thrombosis in vessels with pre-present atherosclerotic plaques or stenosis. 2, embolism, urothrombus inside the heart. 3, an arterial lesion upstream. Or 4, as a result of trauma. Diabetes is a major contributor to peripheral artery disease, and it's traditionally divided into 4 ranges by Fontaine. 1, asymptomatic, the ABI is less than 0.9. 2, purposeful pains or claudication. 3, rest pains. And 4, non-restoration ulcers or gangrene. The occurrence of symptoms of peripheral arterial disease is 3 to 4% among 60 to 65-year-olds, but increasing to 15 to 20% in individuals 85 to 90. Comparable findings have been reported in the U.S. I guess this is a Pakistani, there's a Pakistani article I'm reading, but still has some relevant information. When looked looking at asymptomatic instances where the ABI is less than 0, 9, the occurrence is much higher, and about 20% of all folks above 65 years of age, ranging from 10% in individuals 60 to 65 years of age to nearly 50% of those aged 85 to 90, and vital limb ischemia is defined as an ABI of less than 0. I'm sorry, I'm trying to figure out how an ABI can be less than 0, but that's what it says here, so forgive me. I'm just reading from this article. Anyway, the relaxation aches or non-healing ulcers occur in 1% of the elderly 65 years and older. The incidence of PAD in people with diabetes, the prevalence of PAD in human beings with diabetes depends on the typical arteriosclerosis threat factors and the duration of the diabetes. Few demographic studies have been conducted on the general population. The use of the ABI less than 0.9 as the choice criteria. So, just as an aside note, the article looks like a very well summarized, concise, and detailed review of the disease, but it's the way it's written. To be honest, it's some things are not clear. It is an open access article from Pakistan, and I don't mean to put down the authors. It's just that there's the way they wrote it. I'm not sure if it's because they're not an English speaker. There's something a little off with some of it. So I'm using a few other sources here, so forgive me. I didn't realize that when I selected this article, but just trying to keep it real. And I found something from Stanford. This is going over the ABI Index. So how do you interpret that? Well, if it's 1.0 to 1.4, that's normal. If it's 0.9 to 1.0, it's acceptable, and you don't need to refer these patients to vascular specialists. If it's 0.8 to 0.9, then there's some arterial disease, and you got to treat the risk factors, tell them to stop smoking, etc., control their blood sugars. If it's 0.5 to 0.8, it's moderate arterial disease, refer to a vascular specialist. If it's less than 0.5, then severe arterial disease, refer to vascular specialist. I think part of what I'm getting caught up in with that article is they mention less than 0, which kind of didn't make any sense to me. I don't remember there ever being a negative ABI index. Anyway, the risk factors: hypertension, diabetes, smoking, hypercholesterolemia, and PAD does have a major negative impact on health. I have a better reference here, so sorry for all that back and forth. In terms of, the main study is the ankle-brachial index, as we mentioned, the ABI. It's simple, non-invasive, cost-effective to identify patients. Has very high specificity but low sensitivity in predicting cardiovascular outcomes. And there's a lot of details about pathophysiology, which I'm not going to get into because this is a pain board, it's not a vascular board. I think we need to know about the disease, how to evaluate it, when to refer to a specialist, as well as modifying risk factors for our patients. There are basics of the discussion we should all be having, such as stop smoking, etc. But in terms of testing for ABI is pretty standard. Ultrasound, if you suspect DVT especially. CT angiography can also be indicated. For, of course, a thorough physical exam, checking pulses, skin color, temperature. Look for signs of reduced blood flow, such as loss of hair on an extremity. Ankle-brachial index, Doppler ultrasound we mentioned. Treadmill exercise test can also cause symptoms. Pulse volume recordings measure the change in the the volume of the blood in the legs during each heartbeat. Okay, this is a big word. Photoplethysmography, or PPG. I'll just call it PPG. Monitor blood circulation by measuring changes in light reflected from the skin. Segmental pressure measurements measure blood flow at different points along the leg, helping pinpoint areas of reduced blood flow. Transcutaneous oximetry measures oxygen levels in tissues of the legs, which can be low in PVD. And then there's the imaging studies, like I mentioned, the CTA or CT angiography, magnetic resonance angiography or MRA, arteriography. Well, blood tests, you're looking for like risk factors like cholesterol, and family history is important. So I'm moving on from the, I guess, cardiology or vascular literature more to the pain management literature. And this reference goes more targeted, of course, to pain. So we're talking about PAD or Peripheral Arterial Disease, asymptomatic in the early stages. Up to 50% of patients do progress to symptomatic, which the main symptom is pain. Chronic, gradually worsening pain frequency and intensity, and exacerbations with acute exacerbations. Clinical manifestations vary from intermittent claudication to critical limb ischemia. Of note, the critical limb ischemia without treatment can cause tissue and limb loss. Cramp-like pain in the muscle groups distal to the arteriosclerotic lesions, buttocks, and thigh claudication indicate aortoiliac segments of the disease, whereas calf claudication indicates femoral popliteal segmental disease. Intermittent claudication follows this pattern. Pain is absent at rest. There is adequate blood supply for the tissues. It's triggered by exercise and develops progressively due to muscle ischemia. Is eased by short periods of rest. In the majority of patients, intermittent claudication pain recurs with the same pattern and a similar walking distance. However, some patients may not present with the classic features, but may fall under the leg carry or carry on or leg pain on exertion and rest symptoms. Leg pain that occurs with exertion but not force the patient to stop walking is known as the leg pain carry on. And this article has leg pain leg pain / carry on in quotation marks. While the pain that is consistently triggered by activity but may be present at rest is known as leg pain on exertion and rest. On the other hand, chronic limb ischemia is characterized by severe pain at rest, which is worse on elevation and relieved by dependency. Pain is a result of inadequate tissue perfusion and is often more intense at night due to the absence of the effects of gravity on blood flow. Thus, it is relieved by hanging the lower extremity off the bed or by standing up and walking. Rest pain in chronic limb ischemia may be accompanied by tissue loss ranging from ulcers, frank necrosis, and gangrene, which may lead to major amputation, result in stump pain, phantom limb pain, or post-amputation mechanical pain. So in terms of pathophysiology, you have the nociceptive fibers, which or nerve endings, which get triggered by ischemia, acute ischemia early onset, also ischemia at the end stage, and stump pain with mechanical pain after limb amputation. You have neuropathic pain from ischemia and stump pain. Then you have a mixed picture with the ischemia, like a CRPS, like stump pain, phantom limb pain, and mechanical pain after limb amputation. So we talked a little bit about the etiologies. I'm going to skip through that. Just some mention to the pathophysiology of the pain. Nociceptive pain is mediated through nociceptive receptors located on the outer and middle layer of the wall of large and medium-sized arteries. Receptors may be activated by dilation or dissection, whereas the painful stimulus is often further enhanced by stimulation of the autonomic nervous system fibers that cover larger vessels such as the aorta. Moreover, in patients with PAD, nociceptive pain further escalates because of the destruction of tissues by chronic inflammation, which in turn activates somatosensory nervous systems. The surge of inflammatory mediators includes cytokines and chemokines, triggers nociceptors, and subsequently downregulates their threshold, which is a phenomenon known as peripheral sensitization. We've all heard of that. The state of increased responsiveness is responsible for the activation of the threshold of pain pathways from non-painful or lower threshold stimuli for the perceived aggravation response to the noxious stimulation. Neuropathic pain is a result of a lesion or disease of the somatosensory system. This may have an impact on function of the or structure of the somatosensory nervous system, leading to sensory loss and increased responsiveness to noxious or innocuous stimuli. Neuropathic pain is a critical component of chronic limb ischemia, indicating the long-term nature of the underlying disease. There's a suggestion that alterations in the ion channels, the G protein-coupled receptors, neurotransmitters, and central activation constitute the main pathological components of neuropathic pain. Moving on to the mixed pain, both in intermittent claudication and chronic limb ischemia, where both neuropathic and nociceptive pain elements coexist with severe chronic inflammation, constitutes a typical example. There's increased responsiveness of the brain and spinal cord nociceptors to normal or below normal intensity of afferent stimulation. The changes with subsequent modifications of vascular network reactivity indicate the existence of central complex regional pain syndromes, which may play a key role in the phantom limb, which can eventually develop in these patients. So in terms of managing the pain, finally, we're going to get to that, right? So there's lots of ways: invasive, non-invasive, holistic, pharmacological. In terms of pharmacological strategies, here they're talking about paracetamol, NSAIDs, ibuprofen, naproxen, neuropathic pain using lidocaine patches or prilocaine. Okay, so let me just rewind. Nociceptive, the NSAIDs, anti-inflammatories. Neuropathic, the lidocaine patches or prilocaine. For the mixed picture I mentioned above, capsaicin transdermal patches, which I'm not really using much of, I admit. They're also talking now about for moderate pain. That was for mild pain. And I'm going to have this reference here. By the way, the first article that was giving me trouble, I'm omitting it from the references because it's, I guess, I don't think it was really well proofread, so I just don't want to feed you anything that may or may not be properly done and full of errors. Anyway, the articles I'm sharing are the good ones. So they're also recommending for the mixed picture, you could try gabapentin, duloxetine, amitriptyline. For the neuropathic component, they are suggesting ketamine. And then nociceptive component, once again, paracetamol or NSAIDs. Now, for the severe pain, they're talking morphine, fentanyl, ketamine, lidocaine, IV, dexmedetomidine. And based on the fact that they're pushing paracetamol, I suspect this is not from the States, this article, and I'm just trying to look at it's from Turkey, I think. Anyway, so just keep that in mind. But it's a good article. Anyway, for the mixed picture, magnesium, IV, dexamethasone, IV, morphine, IV, fentanyl, IV, lidocaine, IV, dexmedetomidine, IV. Now, you need to have infusion services, so this might need to be like inpatient management, right? We're giving ketamine, we're giving lidocaine IV. Some offices can do this, but you just need to, do what's in your capabilities. Now, in terms of invasive techniques, they are talking about for treating stump pain and phantom limb pain with peripheral nerve blocks with clonidine added to the local anesthetic solution as a gold standard. I am not adding clonidine to injections in my office. If you're in the States, I don't think you're doing it either. But I've done it with spinals years ago, not recently. Something to consider, I guess. And they're suggesting you could do, for the knee amputations, block of the sciatic nerve may be sufficient, or femoral nerve, depending on the pain distribution. And this is for patients with scores over 7. So although this is not in the U.S., they're not even mentioned spinal cord stimulation, which people have used, especially in Europe, for ischemic pain of the lower extremity. Anyway, other therapies which are non-interventional include, they list music therapy, aromatherapy, psychotherapy, massage, acupuncture, TENS, and then infiltration or massage of trigger points, which I guess you could say is sort of invasive if you're infiltrating anything with a needle. Intermittent pneumatic compression, and then lifestyle changes. As far as the intermittent pneumatic compression, there is a lack of high quality data, so take that with a grain of salt, but they think it can improve blood flow and venous outflow. There could be an increase in the shear stress and release of nitric oxide by the endothelium, lead to vasodilation, decreased peripheral vascular resistance. I remember we talked in the past about sympathetic blocks, but those, I guess, are short-term treatments, so maybe that's why it's not listed here, or maybe, it's not standard of care, I guess. It's more invasive care, but I guess if somebody is really desperate and nothing's working, and this is a tough thing to treat, I would consider that if the benefits could potentially outweigh the risk, and that's an individual decision. So, I hope this was helpful. This is on the boards. I've been getting some good keyword information from some good sources of people who took the boards. So that's why I spent so much time on this talk today. And I apologize for my first reference not being on par with what I normally expect from a published work. But the references I am putting on the show notes and on my website are quality references. And take a look at them if you like. Anyway, I hope to see you guys at the courses. Once again, if you're interested in any ultrasound training, whether privately shadowing me in my office or yours, or coming to one of the ultrasound courses in New York or elsewhere, I will also be teaching at ASPN and Pain Week. So I hope to see you there, and hope to make it to Latin American Pain Society as well. And I'm sorry I can't make it to ASIP, but it's going to be a great conference this year. Take care and good luck.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.